السلام عليكم ورحمة الله وبركاته. معكم دكتور فراس موفق حسن، أستاذ مساعد في كلية طب جامعة الكوفة، اختصاصي طب وجراحة الأنف والأذن والحنجرة. Our lecture today is about the diseases of the ear. Here, before going to the diseases of the ear, we will talking about short notes about an overview about the anatomy of the ear. The ear consists of three main parts: the external ear, the middle ear, and the inner ear. The external ear consists of the auricles and the cholesteatoma canal, and this canal is at the tympanic membrane. And this tympanic membrane represents the border between the middle ear and the external ear. The middle ear cleft is that part of the ear that also consists of three main structures, which is the middle ear cavity proper, the Eustachian tube, and the mastoid air cell system. And this middle ear is the organ or part of the ear that's responsible for magnifications of the sounds and represent as a lever that make the sounds more magnifying to be received by the inner ear. Of course, this middle ear cavity containing the middle ear ossicles, the muscles and ligaments, and also housing nerves and blood vessels. The inner ear is the labyrinth, and this is the organ of hearing and balance, and it consists of the cochlea, the vestibule, and the semicircular canals. And this inner ear is connecting to the vestibular cochlear nerves that is responsible for convey the signals of the ear to the higher center in the brain. For the disease of the ear, we will divide the diseases according to the anatomical structures of the ear into disease of the external ear, those affecting the pinna, and the disease affecting the external canal. Also, we will talking about the disease of the middle ear, the tympanic membrane pathologies, the Eustachian tube dysfunctions, and the chronic suppurative otitis media. And also, we will talk about the inner ear disease, cochlear disease, and the vestibular pathologies. For the external ear diseases, we will, as I said, divide the disease into disease affecting the auricle and those affecting the external auditory canal. And before going to discuss in details these diseases, we have to know some points about the structures of the external ear. It is very important to know that the external ear covered by skin, and this skin is similar to the skin anywhere, containing the skin appendages, containing hair, pilosebaceous units, sweaty glands. So many dermatological diseases which occurs elsewhere or anywhere in the body can affect these parts of the ear. So the external ear main diseases is a dermatological disease. Regarding the auricle, that part of the external ear, which is obvious and it is externally located, before going to discuss the pathology, especially the congenital pathologies of the auricle, we have to know the normal anatomy of the auricle. Of course, there is no auricle similar to the other auricles of the human being. Every human being has his own auricle. But there are main structure or main features of the auricle which all the human beings are sharing. We have the helix, we have the antihelix, we have the tragus, antipterygus, we have the triangular fossa, we have the concussimba, and we have the lobule. So when we have these structures in the auricle, we say that this auricle is normal. Okay? We cannot as precisely determine that this auricle is exactly similar to another auricle. Of course not. But presence of these features mean that this auricle is normal. Absence or deformity of one of these features mean that the auricle is abnormal. To exactly and precisely examine the auricle and determine the features we mentioned, we have to always examine the ear from the front, from the side, from behind. This is very important to look for all the directions and all the faces of the auricle, and we have to compare between both sides. Never forget to examine both sides. If there's any problem in the right side, we have to examine the right and the left and make a comparison. As we mentioned, there are main features which represent as a normal features of the auricle and all the human beings are sharing. And we mentioned that missing or deformity of one of these features means that the auricle is abnormal. For the congenital deformities, we have to look for one of these features when are missed, or to look for deformity. Look here, there is deformity of the antihelix in the first picture on the left side. In the second picture, there is a small deformed auricle, which we call it microtia. In the third picture, there is a small orifice, or there is a small pit in front of the descending across of the helix, meaning that the patients have which we call it preauricular sinus. And in the last picture on the right side, there is a small tag in front of the tragus, which we regard as a accessory auricle. In this deformity, the second deformity is the acquired pinna deformities. This acquired pinna deformities, there are multiple causes of acquired pinna, but the main causes of acquired pinna deformities is the trauma. And also the trauma, of course, there are multiple mechanisms, multiple causes. We have the trauma causing a laceration, cutting wound in the auricle when the trauma are penetrating. As in the picture, there is a cutting of the pinna because of the penetrating trauma. In this situation, we have to deal with this wound precisely in aseptic techniques. Of course, not to miss that this is a human being. This trauma may causing other trauma to the head, may causing blood loss, may causing disturbance of consciousness of the patients. So we have to follow the ABC in treating these patients, and then we have to direct our work to the ear. For this ear, we have to clean the wound, we have to remove the bridge, and we have to try to suturing this wound under complete aseptic environment. And in this condition, we have to make skin edge to edge. We have to cover all the exposed cartilage to prevent further cartilage necrosis and further deformity. This is another pathology, acquired pathology affecting the auricle. It's caused by a trauma, but here the type of trauma is not penetrating trauma. not lacerating trauma. The trauma here is a blunt trauma, causing a force on the auricle, and this force result in rupture of blood vessels of the auricle. The blood vessels here is in the perichondrium. As we know, the cartilage is avascular. There is no blood supply on the blood vessels within the cartilage. The blood supply of the cartilage coming from the perichondrium by a mechanism we call it diffusion. When there is rupture of blood vessels in the perichondrium because of the shearing force of the blunt trauma, this blood vessel rupture causing a bleeding, and the bleeding here is not escaping out because, as we said, there is no penetrating trauma, there is no cutting of the skin. Here the blood will be accumulated in the subperichondrial plane, mean between the perichondrium and the cartilage. And because the cartilage need the perichondrium for the feeding, for the oxygenation, for the blood supply, accumulation of the blood between the perichondrium and the cartilage result in avascular necrosis of the perichondrium of the cartilage, and may result in a cartilage necrosis, cartilage resorption, and deformity. For treatment of this condition, the hematoma should be evacuated as soon as possible, and this evacuation should be done under complete aseptic environment, because persistent hematoma, as we said, result in deformity, cartilage necrosis, and sometimes resorption with cauliflower deformity. And also badly treated hematoma by just simple aspiration or incomplete evacuation, or when treated with septic environment, this will lead to infection, and sometimes this hematoma will be converted to abscess, and also the abscess as a sequelae will lead to deformity. Here is a picture of patients with previous untreated or badly treated hematoma oris, result in auricle deformity. We call it a cauliflower ear. Here we will go to another section of the external ear, which is the external canal, external ear canal. The canal, as we said, is a part of the external ear, lined by skin. It extends from the orifice of the external auditory canal and end medially at the tympanic membrane. And the skin here is in continuation with the skin of the auricle. This external canal consists of two parts. There is a lateral cartilaginous portion, represent about 1/3 of the canal, and medial bony portion represent about 2/3 of the canal. The total length of the canal is about 2.5 centimeters. Here we have to mention some important points, that the skin covering the cartilaginous portion of the canal differs in its histology from the skin covers the bony portion or medial portion of the canal. The difference here in the skin appendages. What I mean that the skin covering the cartilaginous portion, what I mean the lateral 1/3 portion of the canal containing the skin appendages, parasebaceous units, and the ceruminous gland, which are the modified sweaty glands, while the skin covering the medial portion of the canal, between brackets the bony portion of the canal, is just squamous epithelium or keratinizing stratified squamous epithelium. It is devoid, lacking the parasebaceous units and also lacking the ceruminous gland. And this is very important points, and these points I will mention later has a clinical significance. One of the conditions affecting the external auditory canal, it is a common condition, is the foreign body. Foreign body in the canal طبعا has multiple causes and of multiple variety. One of the causes of foreign body is someone inserting something inside his canal. For example, in the child putting foreign body, putting papers, cotton piece, beams, vegetables, whatever the materials inside the canal. Sometimes the cotton buds, because of one using the cotton buds or buds inside the canal for cleaning, and this is bad, of course bad practice, and this cotton will be inserted and put inside the canal and lost as a foreign body. Sometimes insects entering the canal while the patient is asleep in the farms or outdoor, and this insects also regard as a foreign body. How we can treat this foreign body? Of course by removal. But before removal we have to know the type of this foreign body and how we can remove and under which condition. Of course, the type of this foreign body, the constitution of material is of paramount importance, because as a materials we classify these foreign body into two types. We have organic foreign body and inorganic foreign body. The organic foreign body, like vegetables, like the insects, is irritating foreign body, because these organic materials are hydrophilic. These materials will get swelling by fluids and exert a local inflammatory reaction. And if we neglect this foreign body or delay in treating this foreign body will lead to local irritations, inflammations, and infection. And these foreign body should be removed as early as possible. How we can remove this foreign body? Under which condition? We can remove this foreign body by forceps, by hooks, by syringing, and this is under local anesthesia, unless the patient is child or irritable, cannot withstand the local anesthesia environment. In this condition we have to go to the general anesthesia and remove this foreign body in the surgical theater. Regarding the inorganic foreign body, most inorganic foreign body are not irritants, inert material, and these material not exert local inflammatory action unless there is another cause of infections or inflammation. The drawback of this foreign body is just causing blockage of the canal and deafness. Of course we have to remove this foreign body, but there is no urgency in removing of this foreign body. We can postpone the removal and the day after, 2 days after, because this foreign body not danger, doesn't exert local inflammatory action. Of course we have to use also the forceps, the hooks, the syringing, and of course we can choose the local anesthesia and general anesthesia according to the patient status. There are some types of foreign body which are inorganic but risky foreign body, exerts a local inflammatory action, severe inflammatory action, severe destructive lesions. These are the battery cells. The battery cells is foreign body that exerts chemical reactions, and these battery cells, if untreated or delayed in treating or removing, this will lead to destructive lesions in the canal, destructive lesions in the tympanic membrane, in the ossicles, and this destructive lesions is a rapid destructive lesions. So we have to remove this foreign body as early as possible. Another condition affecting the external canal is the wax. The wax is normal material, physiological material produced within the canal and represent as a defense mechanism. The constitution of the wax is the desquamated epithelium. As we know, the canal containing the skin, and the skin is a keratinizing stratified squamous epithelium like the skin, and this skin anywhere is exposed to desquamation, and of course the canal skin is also desquamated, and these desquamated materials will constitute part of the wax. In addition to the desiccated squamous epithelium, there is a sebum, and this sebum produced by the sebaceous glands. And the third constitution of the wax is the cerumen, and this cerumen is produced by the ceruminous glands, which are the modified sweaty glands. So the wax consists of the desiccated epithelium, the sebum, and the cerumen. All these three structures constitute the wax, and the wax may be dry wax, may be wet wax. The color brown, red, blue, black, white. There differs from patient to or from person to person. What is the problem in the wax? There is no problem in the wax at all. The wax is normal defense mechanism. And the wax from its constitution should be produced in the outer 1/3 of the canal. As we said, the outer 1/3 of the canal is the part of the skin containing the skin appendages, containing the sweaty glands, containing the pilosebaceous unit. So, when we have wax, this should be present in the outer canal, not in the inner canal, because the inner canal skin, or the skin that covering the inner parts of the canal, is lacking of the materials or lacking of the histological types that producing the wax. So presence of the wax inside the canal mean either one of two conditions: either the wax is pushed by the person by using of the cotton buds insides, and this pushing of the wax make it in the medial part of the canal, or there is pathology causing accumulation of the crust materials inside the canal, and this is not true wax. So we will return back to the wax. What are the problems with the wax? There is no problem of wax at all, but when the wax produced in a large amount of materials and causing a blockage of the external canal, here we call these conditions as wax impaction, and this is the pathology. Wax is not disease. Wax impaction is the disease, and where there is wax impaction, here we have to remove the wax to improve the hearing of the patient. Otherwise, there is no problem in the wax at all. The last topic to be discussed about the conditions affecting the external canal is the infection. Infection and inflammations of the canal named otitis externa. And these otitis externa either localized when there is infection of the pilosebaceous units of the external 1/3 of the canal, we call it furunculosis, and we have generalized otitis externa where all the skin is involved. Main pathogens affecting the canal and causing infection is the bacteria, and the main bacteria is Staphylococcus aureus, Pseudomonas aeruginosa, and these infections causing pain, pathologia, discharge, serous discharge, sometimes seropurulent discharge or serosanguineous discharge, and a blockage of the canal because of the edema, and these blockage will lead to deafness. How we can treat these infections? These infections should be treated by cleaning of the canal, giving local antibiotics with steroids sometimes to prevent the edema and decrease the inflammation, and avoid water entering of the canal by advise the patients for dry water precaution. These for the bacteria. We have another pathogens also affecting the canal. These pathogens are the fungi, and the fungi causing otomycosis. We have two types of otomycosis. We have Candida and we have the Aspergillus, and both of them causing otomycosis, sometimes in a separate conditions, and sometimes we can get or we can find mixture of these fungi inside the canal. And these fungal infection should be treated also by removal of these fungal debris, and give the patients local antifungal preparation. Of course, the fungal infection causing symptoms similar to bacterial infections: the pain, irritations, tinnitus, blockage when the fungus blocking completely the canal. The second part of the ear is the middle ear. The middle ear is that part of the ear that lie between the external ear and the inner ear. The middle ear cleft consists of middle ear cavity, Eustachian tube, and mastoid air cell system. The middle ear cavity is a 6-wall box, has a tympanic membrane on its lateral surface. Separate this 6-wall box from the external auditory canal. There is a bony roof of the middle ear, represent the tegmen tympani, which separate the middle ear cavity from the middle cranial fossa. The floor of the middle ear is also a bony plate, separate the cavity from the jugular bulb. Anteriorly, the middle ear cavity walls containing a hole for the Eustachian tube, and posteriorly there is also another hole for the Otitis ad intrum leading to the mastoid air cell system, and on the posterior wall, there is a vertical portion of the facial nerve and its bony canal. The medial surface of the middle ear cavity containing the horizontal portion of the facial nerve, containing the oval window, round window, and there is the indentations of the lateral labyrinthine canal. Tympanic membrane, as we said, is represent the lateral wall of the middle ear cavity, and this membrane separating the external auditory canal from the middle ear cavity. Really, the tympanic membrane in histology consists of 3 layers. The external layer is a squamous epithelium, which is in continuation with the squamous epithelium of the inner 2/3 of the bony external auditory canal. There is middle fibrous layer, and there is inner mucosal layer. This inner mucosal layer is in a continuation with the mucosa of the middle ear cleft. When we see the tympanic membrane from the external auditory canal, there is a landmarks that from these landmarks we can identify that this is a tympanic membrane. We have to identify the color of tympanic membrane, which is a pearly gray color in normal condition. We can identify the handle of malus extending in the center of tympanic membrane, ending with the umbo. There is lateral process of the malus, and there is a triangular area in the anterior inferior portion of tympanic membrane extending from the umbo anterior inferiorly, and this triangular area is which we call it light reflex. Okay, the tympanic membrane consists of 2 portions on its lateral surface as a lateral landmarks of tympanic membrane. There is a pars tensa, which is lie behind or below the malleolar folds, and there is pars flaccida, which is a thin part of tympanic membrane that lie above the malleolar folds. And the pars flaccida separate the canal from a part of the middle ear, which we call it the attic. Here we will talking about the disease of tympanic membrane. The tympanic membrane mostly affected by perforation, and there are multiple types of perforation according to the size, site, causes of this perforation. The most common cause of tympanic membrane perforation is perforation that occur after an attack of acute middle ear infection, what we call it acute suppurative otitis media, when there is a pressure of the pus collecting behind the tympanic membrane, and these pressure pus will be built up continuously that causing the necrosis of tympanic membrane and tracking out of the pus outside the middle ear cavity through the extensatory canal. The other causes of tympanic membrane perforation is the traumatic perforation that occur after trauma. And there are multiple causes of this trauma, maybe iatrogenic trauma. We have also external trauma by slap, by pressure, or by penetrating objects entering the canal and affecting the tympanic membrane. The other types of tympanic membrane perforation are those perforations occurring after or occurring because of chronic middle ear disease, which we call it chronic perforations. And these chronic perforations occur because of recurrent attacks of acute tympanic membrane perforations or because of unhealed traumatic perforation. And there are also multiple types of chronic perforation. We have the central perforation, when the perforation is surrounding by a rim of tympanic membrane, and we have a marginal perforation when the perforation reaching the tympanic annulus, and these marginal perforation is dangerous perforation or are dangerous perforation because these associated with otitis and bone erosion and higher rate of complication. Here we will talking about the examination of the external canal and the tympanic membrane. The external canal and the tympanic membrane examination, we call it the oroscopy. The oroscopy is the examination of the ear canal and the tympanic membrane by magnification. And the device used to do this examination is, we call it the otoscope. How we can perform this examination? First, we have to choose the ear we want to examine. If we choose the right ear, for example, we have to hold the oroscope by the right hand, and vice versa. We have to hold the oroscope like a pen, okay, and gently using the other hand. For example, we are now examining the right ear. We are holding the oroscope by the right hand, and by the left hand we gently retract the auricle backward and upward. This is in adult. In pediatric, we have to gently pull the auricle backward and downward. These movements of the auricle is aimed to just straight the canal in order to inserting the oroscope in a smooth way and perform the examination in an obvious way. Regarding the middle ear, as we said, the middle ear cleft consists of middle ear cavity proper, Eustachian tube, and the mastoid air cell system. The middle ear cavity, we mentioned that it is a 6-wall box, and we discussed these anatomical parts of the middle ear. Inside the middle ear there are the ossicles, and there are muscles and ligaments and containing nerves and blood vessels. The ossicles, there are 3 ossicles: the malus, that is connected to the tympanic membrane; incus is between the malus and the stapes; and the stapes, that consists of stapes superstructures, 2 crura, anterior and posterior crura, and the footplate of the stapes, which covers the oval window. So the ossicles is transmitting the sounds from the tympanic membrane to the oval window, and this transmission of the sound is in a way of magnification, a way of magnifications of the sounds from the tympanic membrane to the oval window, and from that to the inner ear. The muscles of the middle ear, these muscles are 2 muscles. We have the tensor tympani and the stapedius muscle, and these muscles attached to the ossicles. The main functions of these muscles is to protect the inner ear from the loud sound, is act as a shock absorbers, to dampen any loud sounds to protect the inner ear. Eustachian tube dysfunction. Before talking about the Eustachian tube dysfunction, we have to talk short notes about the Eustachian tube. The Eustachian or Eustachian tube is a fibromuscular tube connecting the middle ear cavity to the nasopharynx, and this tube is lined by respiratory mucosa. What are the main function of this tube? The main function of this tube is to equalize the pressure of the middle ear to the atmosphere. Okay, and this equalization of the pressure will maintain the aerations of middle ear cavity to make the middle ear cavity function in its top stage. What I mean in this is the middle ear function to be performed in a good way need the ossicles to be moved in a good way, and the ossicular movement need a well aerations of the middle ear cavity, and well aeration of middle ear cavity need well functioning of the Eustachian tube. When there is dysfunction of the Eustachian tube by any cause, for example obstructions of the nasopharyngeal orifice by hypertrophy of adenoid tissue, or by any nasopharyngeal infection or nasal pathologies or postnasal mass, this will lead to a condition we call it a negative middle ear pressure, and this negative middle ear pressure will lead to pulling in of the tympanic membrane. Between brackets we call this condition as a tympanic retraction. Another disease affecting the middle ear cavity is the infection. The infection of middle ear cavity named otitis media. We have acute otitis media caused by acute sudden onset of middle ear infection, mainly because of upper respiratory infection, and this infection will extend from the postnasal space through the Eustachian tube to the middle ear cavity. Most probably this infection is caused by bacterial infection, and this bacterial infection will lead to developing signs and symptoms of acute otitis media, which are pain in the ear, otalgia, deafness, sometimes rupture of tympanic membrane with discharge, and sometimes more serious complication when the infection not treated well. On examination, we will see that the tympanic membrane is red, hyperemic, congested, and sometimes when there is pus behind this tympanic membrane, we will see that the tympanic membrane is bulged, is not pulling in, here is pulled out. And sometimes when there is rupture of tympanic membrane, we can see the perforation with the tracking of the pus through this perforation. Otitis media with effusion, or we call it a glue ear, this occurs because of long-standing Eustachian tube obstruction. We said that Eustachian tube obstruction will lead to negative middle ear pressure and retraction of tympanic membrane. This negative middle ear pressure, if persists, will lead to effusion of the fluid within the tympanic membrane, and this fluid is almost sterile, not bacterial fluids, containing mucus, and when the concentration of this mucus is increased, this will lead to make a glue sensation for this fluid, which we call it a glue ear. The main features of this disease is deafness, a decrease in the hearing, and on examination we will see the tympanic membrane to be retracted, not bulged, retracted, pulling in, and we will see the fluid behind the tympanic membrane. The color will be yellow, brown, sometimes ink color, and there is air bubbles within this fluid in some condition. This picture represents one of the treatment ways of otitis media with effusion. We sometimes, in case of long-standing Eustachian tube dysfunction that lead to otitis media with effusion, and if the condition is not responding well to the conservative measures by using of, for example, intranasal steroid decongestion and antihistamine, when the condition persists despite these conservative measures for at least 3 months, here we have to interfere surgically by doing an incision within the tympanic membrane. We call it myringotomy, aspiration of the glue from this incision and inserting a ventilation tube, or what we call it pressure equalizing tube. We call it between brackets grommets, and this grommet will persist within this tympanic membrane perforation and for a while. There are of course multiple types of grommets. We have short-term grommet that persists for 6 to 9 months. We have intermediate term grommet that persists from 9 to 19 or 18 months, and we have the long-term grommets. We call it T-tube, that persists for years or sometimes for life. The main function of this grommet is to maintain the pressure of the middle ear is equal to the atmospheric pressure, and of course this will maintain the good function of the middle ear and good function of the ossicles and improve hearing. As we said, acute otitis media is the infection and inflammations of middle ear cleft. Sometimes the infection extends beyond the middle ear cavity and beyond this middle ear cleft. When the infection extends beyond the middle ear cavity, here the complications will arise, and these complications are serious complications because the surrounding structures to the middle ear is vital structures. We have brain, we have inner ear structures, we have sigmoid sinus, so meninges. So when the complications arise, here we have to take this condition seriously because the complications of acute otitis media or middle ear suppuration is of high mortality. One of the complications of acute otitis media is the acute mastoiditis. When the infection extends to the mastoid air cell system, leading to the destructions of the trabeculae of the mastoid air cells and converting this mastoid air cell system to a one cavity containing apparent materials. Here we will call it mastoid abscess, and sometimes this abscess will progress to the post-auricular collections and post-auricular abscess. Sometimes the mastoiditis can lead to more extensive infection intracranially and associated with the abscess, for example extradural, subedural or intracranial abscess, and here the mortality rate will be so high if the condition is not treated well or badly or not treated early or badly treated. Thank you. Cholesteatoma is a disease affecting the middle ear. It is a chronic disease and regarded as one of the types of chronic otitis media. Simply, cholesteatoma occur because accumulation of the desiccated epithelium within a retraction pocket sac. How the conditions start? The condition starts when there is a prolonged negative middle ear pressure because of prolonged Eustachian tube dysfunction. As we said, prolonged Eustachian tube dysfunction lead to tympanic membrane retraction. The tympanic membrane will be pulled in toward the tympanic cavity, and when there is retraction or retraction pockets, the desiccation epithelium from the outer layer of the tympanic membrane will fail to migrate through the canal to outside, and this failing of desiccation will lead to fall down of the epithelium within the retraction pockets, and this will be when fall down within the retraction pockets will be a nidus for bacterial superinfection. This is the beginning of the cholesteatoma, and with time the retraction pocket will increase in size, the desiccation epithelium will be increased in size, and the cholesteatoma formation will get increased in size, and this will erode the surrounding bony partitions, bony plates, tegment tympani, sigmoid bony plates, bony walls covering the facial nerve canals, bony walls covering the labyrinth, leading to further complication. How the patients will be presented when he has cholesteatoma? When the patient has cholesteatoma, he will be presented with a discharge from the ear. The discharge will be scanty, offensive discharge, sometimes blood stains, and the patient also complains of hearing loss because of the destructions of the ossicles and sometimes even inner ear dysfunction. On examination, we will see the retraction pockets with a white flex in the bottom of the retraction pockets, and this white flex presents the cholesteatoma, which is caused by the desiccations of the epithelial tissue within the retraction pockets. Another complications of middle ear disease is facial nerve dysfunction. As we know, facial nerve is running through the middle ear cavity on the medial wall as a horizontal facial nerve canal, and in the posterior wall through the vertical facial nerve bony canal. And this facial nerve may be vulnerable to dysfunction, to paralysis, in many diseases affecting the ear. Whatever the condition is acute separative otitis media, or sometimes in case of cholesteatoma, when the cholesteatoma erosion the facial nerve canal and causing facial nerve paralysis.